So Dr. Udeshi, over to you.
Thanks very much. Thanks everyone for joining this late November evening when I'm sure you've got better things to do. So today I'm going to just talk about structural assessment of the shoulder. It's mainly a discussion of MRI, but I will touch on other imaging techniques as well. So the summary of the talk tonight, I'll go through the anatomy very briefly because you all know the anatomy probably better than I. I'll touch on imaging techniques and then the three main conditions that patients present with: impingement, adhesive capsulitis, and instability. And then I've got a few cases at the end that we can do a little quiz with, which will consolidate what I've said before. So going into the anatomy diagram first of all. So an MR scan of the shoulder will include most of this region of interest that we're seeing in this diagram right now. And that's the advantage of MRI over something like ultrasound, where we only get a very small field of view with only what's underneath the footprint of the probe visible. With MRI, we'll see bones, soft tissues, the tendons and the joint fluid, etc., etc. Here's an axial view through the shoulder joint. So humeral head obviously here, bony glenoid here. That darker gray is the hyaline cartilage lining both the glenoid and the articular surface of the humeral head. This little blue triangle at the front and at the back, that's the glenoid labrum. The faint blue at the back and the front, that's the joint capsule. We've got infraspinatus tendon coming through, attaching on the lesser tuberosity back here. We've got biceps tendon in the intertubercular groove here. Obviously, not all structures are included in this diagram. So imaging techniques relevant to the shoulder: plain radiography, ultrasound arthrography, so that can be by under X-ray, it can be under CT or MRI. CT and CT arthrography, MR and MR arthrography. And I'll try and explain when things are indicated and which ones. So here are a couple of examples of plain radiographs which demonstrate an antero-inferior dislocation of the humeral head. You can see here's the bony glenoid, here's the humeral head. The two are not overlapping, not in parallel to each other. And if you do a lateral view of the scapula, so here is the scapula at the back, you can see the bony glenoid as an oval structure in the middle, and the humeral head is not overlapping it. So it's actually dislocated anteriorly and slightly inferiorly, as you can see on the AP. So the plain radiograph is really very good for the bony structures, and it's also very good for calcification. Ultrasound is very high resolution, but it's operator dependent and it gives you a very limited field of view. It can be very quick. It's pretty sensitive for partial and full thickness tears of the rotator cuff tendons, up to 83% accuracy. And it is a dynamic examination, so you can get the patient to move in different positions and see different tendons and different structures. So a few examples of ultrasound images. So this is showing the supraspinatus tendon here, this sort of slightly gray stripy structure. And this is the greater humeral tuberosity with a tendon inserting there. This is a sagittal image or a transverse image to this one. Here's the tendon again. From here to here, there's a slightly separate structure here. That's the long head of biceps tendon. This little dark line above, that's the tiny sliver of fluid in the subacromial bursa. And this is muscle and soft tissues, fat underneath the skin. Here's a biceps tendon, a stripy structure, long lengthways seen in the intertubercular groove. Here's it is on a transverse scan, and there it is again, this gray spotty structure in the groove, which is where it should be. The subscapularis otherwise looks the same as the other tendons, attaching here at the front, and in transverse view, you should see three bundles. So There's one bundle there, there's another bundle there, and there's a third bundle at the back. That's a normal anatomy of the subscapularis tendon. Infraspinatus coming in onto the lesser tuberosity here in the longitudinal and transverse planes. We also see the acromioclavicular joint scanning at the top. So we assess for abnormal widening. We assess for periarticular osteophytes, excess fluid within the joint, bulging of the joint. None of those here. This is a normal ACJ appearance on ultrasound. So here's a supraspinatus tendon. It's shown here in a transverse scan, and you see the darker area in between the crosses here in the top half of the tendon. So this is a partial bursal surface tear. And in the longitudinal direction, that same tear here between the two crosses. It's not full thickness. It hasn't gone all the way down to the articular surface. If it had, you'd expect to see excess fluid within the subacromial bursa. And when we do a dynamic scan with ultrasound, we can assess for impingement, but it is obviously only in one plane, in one place. So here's the acromion process. Here's the humerus, greater tuberosity, and the space between the two is where the supraspinatus tendon should be going through. So that's a pretty narrow space. That's probably around 3 millimeters on this image, and that's pretty narrow. So the patient would also be expected to be complaining of impingement pain in this position. So that's showing us impingement. This scan here is through the posterior surface of the humeral head. A transverse scan is showing this bony defect. So that's the Hill-Sachs defect from previous dislocation. And here's a CT, and you can see how beautifully it demonstrates the bony anatomy. And if there was any calcification in the image, that would show very well as well. So here you can see a fixed dislocation. There's been a posterior subluxation. There's a bony defect or a reverse Hill-Sachs defect here in the humeral head, and the head is stuck in that position. A bony Bankart lesion here on the anterior inferior bony glenoid. You can see that there's a fracture there, and here it is on a coronal image that there's a bony fracture down here. That's a fractured fragment, and there it is on a 3D reconstruction, a little bony fragment sitting here at the front. So MRI, what's the use of MRI? Well, it's really pretty good for impingement, for tendinopathy, full and partial thickness tears. And the gold standard imaging for glenohumeral instability, I would consider as MR arthrography. So for instability, labral tears, that's the best way to diagnose labral pathology, and it will also very nicely show us any full or partial thickness rotator cuff tendon tears. So if we were assessing an MRI shoulder, what are the structures we need to look at? If you do it in a structured way, then you're not going to miss something. So look at the alignment first of all, look for any fluid. Is there any abnormal fluid in any place? Look at the acromion arch, look at the rotator cuff tendons and muscles, look at the rotator interval and the long head of biceps at the front. Look at the glenohumeral joint, the soft tissues, so the labrum and the bony, and then look at any other bones, muscles, vessels, nerves that you can see on the image. So I'm going to show you some examples now. So first of all, impingement. So first thing to say, you don't need imaging to make the diagnosis of shoulder impingement. This really is a clinical diagnosis, and you only should need imaging when there's any difficulty, when they don't respond to initial treatment, or you're suspecting a tear, and particularly if you think it might be a significant tear. So obviously you make your clinical diagnosis. There should be, there often is restricted space between the coracoacromial arch and the humeral head, which causes impingement upon the supraspinatus and or the infraspinatus tendons. Initial treatment, as you would know, is with physical therapies or sometimes with steroid and local anesthetic injection around the tendon to try and reduce any inflammation before your physical therapy can be carried out if there's a lot of pain. So here's an example of a normal looking distal supraspinatus tendon, relatively normal looking. I'll come back to that. This is the acromioclavicular joint. There's no arthropathy, but the acromion process is low-lying. So how do you assess whether it's low-lying? What you look at is the lateral end of the clavicle. You draw a straight line at the undersurface of the clavicle. And if the acromion is dipping below that line, then it's a low-lying acromion. And that one is. Here we've got a low-lying acromion, which is causing impingement. So how do you assess impingement? Well, you look for this fat stripe above the supraspinatus muscle, and it should continue all the way along underneath the acromion, underneath the deltoid muscle, and round the humeral head. So this white fat stripe is sort of missing from here to about here. So that means it's been squashed, it's been squeezed, there's impingement. So this is showing us impingement. Now, all tendons should be black on MRI. And here we've got gray rather than this sort of black color. So that means there's increased signal. That means there's tendinopathy. So there's impingement and tendinopathy of this distal supraspinatus tendon. So you face fat stripe with impingement. Now, the shape, the undersurface shape of the acromion correlates with the frequency of impingement. So type 1 is when it's a nice flat surface, least likely to be associated with impingement. A curved acromion is more likely to be associated with impingement, and a hooked acromion like this, where there's a bony spur or osteophyte at the front, that is even more likely to be associated with impingement. So here's an example of a nice flat undersurface. That's a type 1. And here's a type 2. You can see a mild curve on the end of that, not very badly curved. And then here's a type 3. There's a vicious little osteophyte or bony spur here underneath this acromion, which is impinging upon the distal supraspinatus tendon. And here's the acromion. Here's the lateral end of the clavicle. Here's the coracoid process, and there's a beautiful ligament demonstrated between the two. So we've got the coracoacromial ligament, and this is the coracoacromial arch. So anywhere under this, you can get impingement. Any of these bits can cause impingement on the tendon. So I've already mentioned with impingement, you get increased signal with an intact tendon, and you may get tendon thickening as well. So here's another example of tendinopathy. There's increased signal, these gray areas within this distal tendon. Now, this particular scan, so here's the tendon. Now, actually, most of the tendon looks gray, apart from this small splodgy bit here, which is black. And then on the axial image through that, transverse image through that, we see two black spotty areas. But they're really rather low signal, really rather dark. So that should be raising suspicion that there's calcification in this tendon. And actually, calcification can be quite difficult to spot with MRI. So a calcific tendonitis can be a difficult diagnosis on MRI. We can see the tendinosis, but we sometimes miss the calcification if it's small areas. So that's a place where plain radiographs are very useful. So I would suggest that patients with shoulder pain, they should all have initial plain radiographs to assess for calcification, also to assess how much space there is beneath the acromion. If this humeral head is in contact with the undersurface of the acromion on the plain X-ray, then there's no room for a tendon. So that would be proof that the patient's already got a chronic full thickness rotator cuff tendon tear. So calcific tendonitis, and here's a plain X-ray. This is what it would show you. So here's a very easy diagnosis of calcification in that tendon right next to the greater tuberosity. Now, rotator cuff tendon tears. So they can be acute or chronic. They can be full or partial thickness. They can be intrasubstance. Also alternatively known as rim rent tears. Well, intrasubstance may be a longitudinal split. A rim rent tear is, I'll show you an example in a minute and explain that. So obviously they can affect any of the rotator cuff tendons, and ultrasound and MRI can both diagnose these conditions. So here's a partial tear of the distal supraspinatus tendon. So if you look at the tendon, although the tendon does narrow normally, you can see here it's particularly narrow at this point compared to more distally. So there's a partial undersurface tear here, and that's a very thin distal tendon. So there's no increased fluid. I mean, this is T1 weighted, so it's not easy to spot fluid, but there's no increased fluid within the subacromial bursa, so it's unlikely to be full thickness. Here's an MR arthrogram. So this white stuff is contrast within the shoulder joint that's been injected, and then a T1 fat suppressed image has been obtained. So you see the contrast here, and then the tendon here should be extending from about here to up to the top here. And you can see there's this defect in the undersurface of the tendon. So that's a beautiful demonstration on MR arthrography of a partial undersurface tear of the supraspinatus tendon. And here is a supraspinatus tendon with a full thickness tear. So from here to here, we've got fluid. It's not an arthrogram, it's just normal joint fluid filling the space. So you've got a full thickness tear, and there's more fluid to see here in the subacromial bursa. So that's a full thickness supraspinatus tendon tear, and it's the leading edge where they normally start because that has the most critical blood supply. That's where the blood supply is poorest, so tears usually start at the leading edge. And here's a complete full thickness tear with some tendon retraction. It's no longer attached to the greater tuberosity. It's been pulled back. It's like a rubber band, so it pings away if it's completely torn. And you would then be left with a large bare area overlying the humeral head. I think I've got an example of one of those in a minute. Here it is, in fact. So the supraspinatus muscle sits here, and you can see the muscle is full of fat. This bright stuff is fat. This is a T1 weighted image, and there's hardly any muscle fibers. Look, there's a bit of muscle fiber there, but all the rest of it is fat. And the volume, it should be a nice bulging, biconvex shape. It's not, it's a shriveled little thing sitting here. This is the tendon. You can see it's rather wavy because it's been retracted and it's sitting there all loose and lax. Instead of being attached to the greater tuberosity all the way over here, it's been pulled back by probably around 3 centimeters or more. Here's the AC joint. It's sitting underneath the AC joint. So all this is a large bare area overlying the humeral head. Why is it called bare area? Well, it's the surgeons. When they go in and look at this, they look at the humeral head from above, especially if they're doing an arthroscopy. They come in from here, and all they see is a bare humeral head. It should be covered by tendon, but it isn't. So that's the bare area. And an atrophic supraspinatus muscle. Now, we need the radiographers to remember to take the sagittal slices all the way medially until they see this Y bony shape of the scapula. We want to see this Y because that's where the supraspinatus fossa should be full of supraspinatus muscle. It should look like this, nice and full of muscle bulging top surface. That's telling us that's a normal muscle, that's not atrophic or wasted away. And here are the rest of the muscles, subscapularis, infraspinatus, subscapularis, teres minor. And we now grade muscle atrophy or fatty degeneration is a more important finding. And there's a Goutalier grading, French people, a French radiologist, I think it was, who graded and produced this classification. Now, what's the importance of this? Well, if the muscle is fatty and atrophied, if it's all the muscle is replaced by fat, then particularly in elderly people, it's very difficult if you repair that torn tendon to get normal function back, because if it's a fatty shriveled little thing, the rehab required is pretty, is too much for elderly frail patients to achieve, and so they'll get no benefit at all from repairing that tendon. So there's no point if if there's fatty degeneration of the rotator cuff muscles, there's no point doing surgical repair. So grade 0, no atrophy, no volume loss and no fatty degeneration. Grade 1, you've got some fatty streaks within the supraspinatus and infraspinatus because those two tendons are torn. And then grade 2 is less than 50% of the muscle is involved. Grade 3, 50% of the muscle is involved. And then grade 4, over 50%. So certainly in these 3s and 4s, surgery would not be indicated. Here's another large bare area of like the humeral head. There's retraction, and it's a complete tear of both supraspinatus and infraspinatus tendons. And that's the axial image. Now, of the same patient, you can see there's fatty atrophy of this infraspinatus muscle on this view. Supraspinatus is above this, so you're not seeing that, but you saw it on the previous image. And then if you look in the intertubercular groove, there's no tendon. There should be a black dot in there. The black dot is out here, so it's been dislocated out. So this is a massive rotator cuff failure where you've got full thickness tears of supraspinatus, infraspinatus, and a dislocated biceps tendon. And a dislocated biceps tendon implies that the subscapularis may be abnormal too. And there is a little bit of fatty degeneration. It's not looking the normal muscle intensity. Look at the deltoid. It's not the same color. So there's fat in it. So it's probably the supraspinatus is also torn because the distal tendon forms a fascial sheath overlying the intertubercular groove and forms a roof to the intertubercular groove, which keeps the biceps tendon in its normal place. Okay, so this is an MR arthrogram with a complete full thickness tears, and that's the example that I was just showing you in an arthrogram. Here's a biceps tendon. It should be sitting in the groove here, but on the axial view, it's sitting anteromedially to the shoulder joint. Okay, there's another one. So this is a bony glenoid, humeral head, another biceps groove with no tendon in it. And this is in fact the tendon sitting out here. Okay, so here's another patient with a complete tear of the supraspinatus and infraspinatus tendons. You've got joint fluid, which is leaking out into the subacromial bursa. But there's a bulging joint here filled with gray solid material, and there's more gray mucky stuff in the axillary recess down here. So what's that? Well, that's synovitis within the joint, and you can get it in the subacromial bursa also. So that's telling us this is all very chronic and inflamed. So chronic tear with synovitis. Okay, I mentioned a rim rent tear previously. So rim rent tear is this little bright spot here. So it's actually within the substance of the tendon at its humeral insertion. So that's called a rim rent tear. Now, the symptoms from this will be exactly the same as any other rotator cuff tendon tear. But the point is that if the surgeon goes to look for it, does an arthroscopy, he's not going to find it because look, the superior surface, bursal surface is intact. If he's inside the joint, he's not going to see it because it's actually in the footprint of the insertion of the supraspinatus on the bone. So there's no way a surgeon will see this unless he cuts into the tendon. So this can provide a difficult situation where the surgeon has to work out whether the symptoms are bad enough for him to try and do something surgically, or whether this is going to be so difficult to find that he's going to do more damage than good trying to actually do any repair here. So he may just do a subacromial decompression if some surgery is needed, or we try and keep to conservative treatment to try and reduce the patient's symptoms. Just to mention 3 Tesla MRI. So most of the MRI scanners in this country are 1.5 Tesla. A 3 Tesla MR, we have one here at Cobalt, and the bigger hospital centers might have them too. It's double the magnet strength of a 1.5, which means double signal to noise ratio, better resolution, and increased speed. And we can balance these depending on what we want. Do we want better resolution exclusively, or do we want really fast speed? And it all depends on the patient, what we're trying to achieve. If we're looking for labral pathology, we very often say that we'll only put those patients on a 3 Tesla scanner because we want the highest possible resolution. Another example of tendinopathy where there's increased signal within the supraspinatus tendon, you can see between here and here, the fat stripe stops here. You can't see it going up. And then there's a little bit of fat more distally, so that's impingement. You can get things like this, which is a pinhole tear within the supraspinatus tendon. That can give you very similar symptoms to any other tendon tear. Okay, moving on to capsulitis. If you've got any burning questions, do stick them into the chat. Otherwise, I'll certainly allow time at the end for questions. So adhesive capsulitis, again, uh, this really is a clinical diagnosis, but it can be very difficult because sometimes the symptoms overlap with rotator cuff impingement or tears. So imaging can sometimes help, but it will provide supportive, indicative findings rather than a firm diagnosis. So on MRI, what would we see? We may see increased T2 signal in the soft tissues of the axillary recess. We may see thickening of the axillary recess and coracohumeral ligament. Fat obliteration in the rotator interval is said to be 100% specific of adhesive capsulitis, basically because you get scar tissue and adhesions and the fat gets obliterated. We can get enhancement of the capsule after intravenous contrast because of the inflammatory component. And we can get leakage of contrast and internal septi, in other words, little scars, little septations on MR arthrography. So in glenohumeral instability, we're moving on to now to the third indication. We may see fixed dislocations, which is when plain radiography or CT would be ideal. We may see subluxation, again, well demonstrated in plain radiographs. We may see Hill-Sachs or Bony Bankart lesions. We may see soft tissue Bankart or labral tear. So I've already showed you this example of a anterior-inferior dislocation on plain radiographs. On MRI, other imaging techniques, MRI is pretty good. We hardly ever do CT arthrography these days, but that's another way of diagnosing it, or MR arthrography. And MR arthrography you can do direct or indirect. Direct means injecting contrast into the joint. There is a technique described with indirect arthrography. If you didn't want to inject into the joint for some reason, you can give an intravenous injection, which tends to highlight anything with a good blood supply. And if there is a labral tear, it very often highlights that. But it's much more subtle finding, much more subtle to diagnose it that way than it is with a direct arthrogram. Now, some people will say you don't need arthrography. If you do 3T MRI, you can very well diagnose labral tears, which can be true. It's not always true. And it's much easier with an arthrogram than with a 3T study, high resolution without arthrography. But it is possible without arthrography if you get a really good image. The difficulty is you need to have good working relations and you need to understand your surgeon very well and what they will and will not operate on and how much certainty they need. Because it would be a tragedy if the radiologist said without arthrography, yeah, I think there's a labral tear, and then the surgeon goes in and doesn't find anything. He's not going to be very happy, and neither is the patient. So here's a standard axial image through a shoulder joint. And this dark triangle at the front of the glenoid, that's the labrum. And at the back, it's always a bit more rounded, a bit less obvious, but that's a normal posterior labrum. So there you are, no, completely normal, beautiful image, no abnormality. And here's two examples of the same patient where the anterior triangle is there, but there's this higher signal going through this bit of the anterior labrum, and you can see it there again. So that's a labral tear demonstrated on a standard shoulder MRI scan without arthrography. It's just a little bit more difficult to be absolutely 100% certain, particularly in elderly patients where you will get degenerative signal changes in the labrum. And I like to be absolutely sure before I tell a surgeon that there's a labral tear. And this is what they would do if they did find a labral tear, they'd try and attach it back. They fix it back to the bony glenoid. So you may see on the post-surgical radiographs little tacks like this where they've reattached the labrum to the bone. And on this radiograph here, you can see the Hill-Sachs defect, and you can see the repair of the labrum. So here's what you might see. This is the axial representation. The nose is here at the front, so this is anterior, that's posterior, axial images. So that's a normal glenohumeral joint and labrum. Here's one that's dislocated. So there's a Hill-Sachs defect. Even a single dislocation can give rise to a bony defect like that visible. Um, so that one's showing us a Hill-Sachs defect. I think we're here, there's a bit more color on the bony glenoid side, so there may be a bony Bankart as well. And then this one's after reduction. Then you can see a labral tear on this bit of the diagram here. Um, Now, sometimes on MRI, you'll see a paralabral cyst. So here's the anterior labrum. There is some high signal going through here. This isn't an arthrogram. It's a standard shoulder MRI. And you can see fluid here anteriorly, quite close to the labrum. So that's a paralabral cyst. Well, where did this fluid come from? It must have come from inside the joint. So it's leaked through this tear and it's collected outside the joint. So if you see a paralabral cyst, that's pretty strong evidence that there's an underlying labral tear present. This is an arthrogram. So this is contrast is T1 fat suppressed image. And you can see bits of contrast have leaked through here and are sitting just behind the posterior labrum. So this is another paralabral cyst filling with the injected contrast. Here's a normal coronal view through in an MR arthrogram. So this is all contrast, the white stuff. Here's a biceps tendon attaching to the superior labrum. So that's the biceps anchor. There's a little gray rim on the glenoid, and on the humeral side, that's the hyaline articular cartilage. And that's the same image, same patient, normal scan on a axial. Now here's another axial where there's contrast seeping into the anterior labrum underneath here. There's a bit of normal dark labrum, but otherwise contrast gone in. So this is a disrupted labrum, a torn labrum. And this was quite extensive from going up to down on the glenoid. So this is an extensive labral tear. So here the labrum is sitting out here in the fresh air or in the contrast pool. It should be attached to the glenoid over here. It's pulled up, but there's also this something or other attaching it to the bone still. So that's the periosteum, which has been pulled off along with the torn bit of the labrum. So this is an Alpsar lesion or anterior labral periosteal sleeve avulsion. There's all sorts of acronyms in labral pathology or in shoulder pathology. You don't need to know all the acronyms, but you at least should describe this as a ulcer lesion so that the surgeon knows exactly what he's going to be looking for. So here it is on an abduction external rotation view with the arm abducted and externally rotated. And here's the contrast seeping in underneath this labrum and periosteal sleeve all the way back to the neck of the glenoid. And here's the superior labrum. It should be a nice dark structure, but there's contrast extending into it, or actually it may just be fluid. I'm not sure it's an arthrogram. So it's just fluid extending into it. So this is a slap tear or a superior labral anterior to posterior tear. And this slice is further back than this left-hand one. And you can see the fluid extending all the way between the labrum and the bone. So that's a posterior labral tear. And there's that same posterior labral tear with contrast underneath it here, or fluid. Okay, I think we've gone through that a little bit quicker than I thought. Sorry about that. We've got a few quiz images to look through. So please put your answers in the chat as I'll ask you questions. So here's an MRI scan. It's a standard scan without arthrography. What do you think it shows? Coronal image, T2 weighted. What are we seeing on this? Anybody? Ah, fluid leaking from the joint. Well, we've got axillary recess here. Yeah, so what's this over here? That's a good question. I'm not 100% sure what that is, but there's certainly a tiny bit of fluid in the recess. I think what we're supposed to see here is that it's all very tight. There's really not very much uh, joint space, and if I'm not sure we're seeing the soft tissues of the inferior recess very well, but there is thickening here of the recess. So this was meant to be an example of, whoops, hang on. This is okay, this is an MR arthrogram. And it's meant to suggest adhesive capsulitis. Okay, so here's another patient. And what do we got here? We've got three images. Here's a coronal image. You can see the articular surface of the humeral head and the articular surface of the glenoid are not quite parallel to each other. So there is superior subluxation of the humeral head. And the acromial space is reduced. What should it be normally? Well, on plain X-rays, we would expect it to be 9 to 12 millimeters. On MRI, in patients with shoulder pain, it's rarely that. But if it was anything below 5 or 5-ish, then I would call it reduced. And you can see that the fat stripe is effaced. It's up to here, and then you don't see it. So there's definitely impingement. And then these axial, and that's a sagittal, are very abnormal because you've got bulging of the joint, but it's full of gray stuff. There's a bit of fluid visible here and there, but it's mostly full of gray stuff in the joint. So what is that? What's going on in this joint? What's all that gray material inside the joint space? Yeah, we've got a diagnosis here. That's synovitis. So that's gray stuff in a bulging joint is very, very thick synovium. So that's synovitis. And what are the causes of synovitis? Well, it could be any one of these: rheumatoid arthritis, seronegative, other seronegative spondyloarthropathies, crystal deposition, infection, amyloidosis, pigmented villonodular synovitis, or it could be idiopathic, i.e., we don't know why. Okay, that's the next case. Hang on a second. What's the question here? Is a supraspinatus also calcified? Let's go back. It's very, very dark, isn't it? But then all these images are dark. So I'm not 100% sure, but it's always worth asking that question when the tendon looks very, very dark. Okay, so here's another case. Coronal image through a very abnormal looking shoulder. What do you think's going on here? I've got more images in a moment, but this image is already looking very abnormal, isn't it? What are we seeing?
I think, Umesh, there was just another question from James in the chat.
Uh-huh. What was
Related
it?
to the other one.
I think I've answered the synovitis calcification bit. Okay, very abnormal looking joint. And you can see the acromial space is very, very low, very, very small. There's joint fluid leaked out, so there's no tendon visible here. So there's a complete tear of the supraspinatus and probably infraspinatus as well. Here's the supraspinatus muscle belly. It should be filling this space underneath the clavicle. It isn't. It's a shriveled little thing. So there's at least 50% volume loss. There's a huge osteophyte underneath the humeral head. So that's arising from the humeral head. There's something very abnormal out here, gray stuff, which is probably synovitis. There's a degenerate acromioclavicular joint. There's osteophytes underneath and above. So it's all looking pretty abnormal. And there's this little high signal hole, if you like, in the humeral head. That's probably an erosion or a cyst. So complete rotator cuff tear. And then if we go anteriorly, we see these in the joint fluid, we see these little dark blobs. Any idea what that is? Multiple intra-articular low signal bodies. And here's a sagittal. So this is where we saw all those low signal bodies. The joint is bulging with all this abnormal stuff within it. So that is actually a very florid synovitis. So what happens is the synovium hypertrophies and thickens in a very excessive way, and then it forms little villi, pseudovilli, and then because it's so profuse, it runs out of blood supply, and those little tips of the synovium, the villi, they necrose and fall off and become loose bodies in the joint. So they're called rice bodies. And they used to be more common than now. When rheumatoid arthritis, we didn't have as good treatment as we do now. Here's a bony erosion. There's rice bodies in the joint, and there's erosive changes here at the back of the bony glenoid. Here's all that synovitis in the joint. So this is chronic rheumatoid arthritis. And this is what you would have seen in an olden days. If you did a X-ray arthrogram, you would have seen these little rice bodies in the joint. So that was long-standing rheumatoid arthritis. Okay, so the next patient, we've got here on the left-hand side a radiograph which was taken when the patient first attended clinic. 2 weeks later, symptoms have got much, much worse, and the X-ray looks like this. So there's a rapid change between the two in 2 weeks between the two radiographs. So what's happened? Anybody? What's going on? What do you observe? Subluxed humeral head, cuff tear. Well, yeah, I think it is mildly sublux. It's gone upwards, isn't it? Anything else? Aha. Somebody suggests joint an infection. Well, look at the joint space. You can see a discrete joint space here. It's gone. And then you've got some lucencies on both sides of the joint, in the bony glenoid and in the humeral head. So any problem that affects both sides of the joint, you have to think of infection. So you should have strong suspicion here. And there's some sclerosis as well. The bone is a bit more dense than on the first radiograph. So a bit more dense here, perhaps a bit more dense on this glenoid side. So you should be thinking of septic arthrography. If you think you've got septic arthrography, what should you be doing? After this X-ray, what should you do? You've just had this X-ray done, and somebody suggested to you that this looks like septic arthrography. How do you manage that patient? Absolutely. Flag urgent, admit to hospital. Absolutely right. You do not want to mess around with this condition because it'll probably need a surgical washout. They need to take this patient to theatre. They need to get into that joint and wash it out. That's the only way you're going to save this joint. It's already beginning to be destroyed. If this was a young patient with, it looks like a young patient anyway, but if this was a young athlete, someone like that, um, you do not want to destroy joints. That they're not going to thank you. So what do you think happened? Why have they suddenly got between this left hand X-ray and this right hand X-ray a septic arthritis? What happened? What's the story here? What do doctors do when patients turn up with shoulder pain in their clinic? Absolutely. They've had a steroid injection, haven't they? And they've got a septic arthritis. So this is why I've had one case of septic arthritis in 35 odd years of doing arthrograms, and that patient was poo-pooed by the GP when she went to complain about severe shoulder pain. They said, "Oh, well, you've had an arthrogram, you're bound to have a bit of pain." And then it was very, very late before she actually turned up with the orthopedic clinic again. And she was a young sports keen person, and we did not do her any favors at all, which is now every single patient I do an arthrogram on, I tell them that they should not get severe pain. They should not feel unwell. They should not get nights shakes, shivers, sweating, symptoms like that, because that could mean it's an infection. I tell them to go straight to the GP and get antibiotics if they get any of those symptoms. Although it's a very rare complication, it should be 1 in 10,000, or that sort of number. So here's the same patient's MRI scan. Erosion, so look, dark cortex gone, synovitis and horrible looking joint fluid, and some cystic changes, bony erosion, possibly even a little fracture down here. And that's it on the axial. There's no normal shaped glenoid, no normal shaped humeral head. That's a very severe one. And that's the same image again. Okay, so this is the next case. We're nearly towards the end. So what does this one show? Here's a coronal T1 and an axial T2. What do these images show us? What's abnormal looking on this MRI scan? Yeah, avascular necrosis. So what we've got is a abnormal signal in the subarticular bone of the humeral head. And on the T2 weighted image, you can see a sliver of fluid and then a much darker bone compared to the rest of the bone, which is superficial to that sliver of fluid. So this bone has died. There isn't a normal blood supply, and it has fractured, and a little bit of bone is hanging by a thread, perhaps, and fluid is seeped underneath it. So this is avascular necrosis of the humeral head. So that's what the radiograph would look like. And note, it's only on one side of the joint, not on both sides. So that's not infection. That's affecting the humeral head only. And this is what the patient was treated, had to have a shoulder replacement. There's lots of causes. Here's some examples. So it could be trauma, could be chronic corticosteroid. I don't know if I've got divers disease in here, but divers get avascular necrosis, sickle cell, alcohol, SLE, hyperlipidemias, HIV, all these other ones are all causes of avascular necrosis. Okay, I think this will be hopefully the last case. Axial images, we see an MRI scan of the shoulder. There's a little bit of increased fluid in the subacromial bursa, but there's this round fluid intensity signal just behind the glenoid. And then on a higher slice, it seems to be extending uh, anteromedially. What's going on here? What's this fluid containing structure close to the bony glenoid posterior surface? Nice, round, well-defined structure next to the glenoid, full of fluid. It's a paralabral cyst. Here it is on the sagittal, just behind the labrum and extending up into the spinoglenoid notch. And then on another image, we can see a little bit of muscle edema here and here in the supraspinatus and infraspinatus muscles. So what is that telling us? It's a paralabral spinoglenoid notch or cyst. So there must be a labral tear, but what it's doing just here is where the suprascapular nerve sits. So it's compressing the suprascapular nerve, and this muscle edema is telling us that the muscles are becoming denervated because that suprascapular nerve is being compressed. Okay. So there we go. That's just the same what I've just told you. Okay. So we've got to the end of the talk. Are there any other questions? Um, Please do give feedback. We're going to put a little poll on in a moment for you to just fill in. I need feedback for my appraisal, so please do all fill it in. Any questions, anything else, any other comments? Please feel free to put them in the chat. I'll try and answer them. We also, I have a PDF of all the slides. Do write in to the email address you registered with, so education@cobalthealth.co.uk, and ask if you want a PDF of the slides. GP doing unguided injections. Most of the time, unguided injections are very successful, and imaging departments won't be able to cope if we try and do everything with image guidance. I mean, if you have an ultrasound machine or if you have access to it, then you do get a better result with guided injection. So I think it's something like 60% compared to 80% relief. So there is a difference, but the number of patients who get steroid injections, we just wouldn't be able to cope. So I can't advocate that it's only image guided. I guess that in normal everyday practice, if you are used to doing injections, then an unguided injection would be first line. And if you thought, well, that didn't go as I expected it to, then maybe after that you could try a guided one. Patients do need to be consented to say that you can't guarantee a result. That's even with a guided injection. That's what I'll tell them, because um, these things are complex. You never know whether you're actually treating, whether you've got the right diagnosis, or whether either their pathology is more serious than a single injection will help. And especially if you've got a tear of the rotator cuff, then an injection will be of very temporary use. Any other questions? Education events, okay, at cobalthealth.co.uk for PDFs, please, and a recording of the talk. Okay, good. So thank you very much. If we've got a couple more minutes, if anybody's got any more questions, but otherwise we'll call it a day there. If you haven't filled in the poll, please do fill it in. I really do need the feedback for my for my own appraisal. Thank you. Good. Do let me know. Do put in the chat also if you have any particular topics you'd like me to cover next time. We haven't got another date set yet, but I'm sure in the new year I'll be doing another talk. And we are hoping to set up a more extensive sort of MSK conference, perhaps a half-day event, but we think we'll do that in person rather than online. But that's all to be decided. So sometime in the next quarter of the new year, we will be trying to do an MSK conference. Have several speakers covering MSK topics. Okie dokie. So I think I will come out here. I'll stop sharing. And thanks, everyone. Thank you very much. See you next time.